Good morning, everybody. We are about to begin shortly. May I please request everybody to please keep their phones on silent or on vibration mode or switch them off. Requesting everybody to please take their seats. So thank you, everybody. Good morning, ladies and gentlemen, distinguished guests, respected dignitaries, esteemed colleagues and friends. It is my great honor and privilege to welcome all of you to today's event, the official release of the report titled Roadmap to Address Vitamin D Deficiency in India. Vitamin D deficiency is a critical yet often overlooked public healthcare challenge in our country. Despite India being a land blessed with abundant sunlight, a combination of lifestyle changes, evolving dietary habits, and limited public awareness have contributed to a surprising and a widespread insufficiency of this essential nutrient. The consequences of this deficiency are far reaching, from compromised bone health to increased vulnerability to chronic diseases and weakened immune system. The effects of vitamin D deficiency are pervasive across all age groups. Today, we are here not only to acknowledge the scale of this issue, but to take a significant step forward to launch a comprehensive roadmap aimed at tackling vitamin D deficiency in India. This report, developed by esteemed experts and institutes, outlines strategies and policy recommendations to ensure a healthier future for all. It's a call to action, a strategic guide with actionable recommendation to improve public health outcomes and promote nutritional security for all. Throughout this event, we will hear from leading voices in the field who have contributed to this vital initiative. Their insights will shed light on research and challenges ahead and the collaborative efforts needed to implement effective solutions. Once again, thank you all for being here and for lending your support for this critical endeavor. Together, let us pave the way for a healthier, more informed, and nutritionally empowered India. To commence today's proceedings, may I request Dr. Ashish Chaudhary, Managing Director, Akash Healthcare Private Limited, Director, Anvika Foundation, to please come on stage, sir. I would also like to call upon our special addressee, Dr. B. Sasikaran, former Director, National Institute of Nutrition, Indian Council of Medical Research, to join us on stage for this session. Dr. Raghu Arakal, Deputy Director General Ayush, Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India has an urgent meeting. However, he has promised us to join us online. Once he's online, I'll welcome sir. Now, may I request Dr. Arpita Mukherjee, Professor ICRER, and the lead author of this report to please join us on stage. And ma'am, please, your welcome address to the August gathering.
A very, very good morning to all of you. And thank you for joining us. Today, there is a lot of events that are going on. Some we planned, we did not know, some unplanned, and some thanks to the recent developments in the US. Whatever is the case, let me put a perspective of why we did this study. Years ago, ICRER did a study for WHO on on health, looking at the impact of what we eat and what we do not eat, and how do we manage our lifestyle. So that study led to another study, and on what are links to NCDs. Ki, if you have a diabetes, if you have a high blood pressure, what kind of problems do you face? And when you face problems, government and everybody tells you, even the dietary guidelines tell you, have a lot of fruits and vegetables, have a lot of good quality food. Now in our country, half of the population is not able to afford that kind of fruits, vegetables, meat, because the diet is not always affordable. Cost of food is very high, and therefore we were looking into the deficiencies, and we found that in India we have history of addressing deficiency. It's not like first we haven't addressed the deficiency, but when we try to address the deficiency, in a long run, deficiency can lead to illness. For example, we have this double iodized salt to address the iodine deficiency, and now we have the problem of high blood pressure. So how now we need to address high blood pressure, and in many southern states and other, salt is given for free. Now now then came how to address anemia. Now when you're trying to address anemia, again you're talking about another system, and you have an anemia mukt Bharat. So we are targeting the deficiency step by step. Then was the vitamin A deficiency. Again, we have certain programs, there are fortification to address it. Vitamin D deficiency is a silent pandemic. While it is growing and while there is a big knowledge about it, there are three or four issues why this deficiency hasn't been talked about. First problem. The first problem is related to the data in itself. In India, there has been no nationwide survey until recently, when the ICMR NIN is doing their Sampada survey to get a data on the micronutrient deficiency, because you cannot address a deficiency like, let's address vitamin D, then vitamin D, then vitamin C, then iodine. Like that, you cannot run government programs. So let me put it in the broader concept that a government program runs when you bring in a deficiency into the holistic picture of the entire program. And what you tend to do in bringing the deficiency into the holistic picture is to give a holistic solution to the government. And although the title says vitamin D Kuposhan Mukt Bharat, what we tried to do in this was to actually bring together all the experts. They are mostly micronutrient expert. We will not call them, sir, vitamin D expert, vitamin A expert, and so on and so forth. And they would be talking about a holistic approach, because no country can afford to have 15 program running on testing. So if you are doing your testing and you're testing for two types of deficiency, please test for vitamin D deficiency. That's the really key takeaway. And I think if you go for one key takeaway of this program, that is the takeaway that we want to suggest, that existing systems and programs are fairly well equipped to address the deficiency. But, and for that but, I would like to ask a few questions to find out how much we know about the subject. How many types of vitamin D are there? Loud. What are the differences?
Vitamin D3 is generally considered coming from the animal origin. But in recent years, vitamin D3 is also extracted from yeast, which is kind of veg vitamin D3. And D2 is derived from mushrooms. And we are a startup, and we just got our pre-seed.
Okay. Self publicity will be later. But what you ultimately said is that there is a veg version and a non-veg version. Okay, so veg version and non-veg version, well taken. Second question, since we have a lot of doctors here, tell me which of these versions are in the essential drug of the in India, or both? Good. Which is allowed by FSSAI 245? Which is allowed by FSSAI 245? T2. Good. So one is allowed by government to be in essential drug list. One is allowed by FSSAI to fortify. So one part of the system is non-veg, one part of the system is veg. So this veg non-veg is actually a misnomer. Both systems should be veg and non-veg. That's what WHO says. And both system allows the consumer to decide what is a veg and non-veg. Because did you see a FSSAI logo? What does the FSSAI logo with green means? Veg, good. So, and red? Non-veg. So the veg and non-veg products are already in the market. So why you have to think it through? So given this scenario, it gives me great pleasure to actually welcome the thought leader in this area. I'm not the thought leader. I am just an economist. I have no idea about health. Don't go by the doctor in my name. I cannot treat a patient. I am just following a economic and a simple logic to the complex illogical systems and bringing them together into a common comprehensive report. And the thought process as you take back today is that what is possible in this country. In this context, may I now actually introduce the thought leader in this area, Dr. Ashish Chaudhary and Dr. B. Shashikaran. Dr. Shashikaran, I must say, has been the pioneer in ICMR NIN to actually think on this subject through. So he was, and we have a lot of thought leaders here, Dr. Marwa, Seemaji, Ruchika, all of them that, and Dr. Nair, who is now in the FSSAI committee, and we have policymakers joining us online. So they have all thought and given a substantial part of their life to this storyline to bring a synergy across policies to support India to address the deficiency. Over to you, Harpreet ji.
Thank you so much, ma'am. I would like to request Dr. Ashish Chaudhary to please formally welcome Dr. Sasikaran with a token of our appreciation. Thank you, sir. It is with great pride that I introduce to you all a visionary who sees the healthcare as both a science and service. Guided by compassion and innovation, he blends clinical excellence with purpose-driven leadership to heal, uplift and transform lives. The man behind this noble initiative and the chair of this session, Dr. Ashish Chaudhary. So may I request you to please shine some light on the burning topic of the day. Thank you, sir.
Good morning, all. Well, it is a heartwarming moment for me. Looking back, if I recall correctly, it was 18th of February last year when we met first time, Dr. Arpita Nikriyar. On my request, Gulpreet, our PR head, she actually arranged this meeting. And that time, there were a lot of questions in my mind about vitamin D and my experience as a clinician. Is there something as a doctor, can I make difference apart from the patients who are visiting my clinic or the hospital? Can vitamin D, which is of course very close to my heart and my practice, and likewise many of my clinicians would resonate how much vitamin D affects their patients, and even the surgical outcomes vary significantly once we know the vitamin D involvement and affection of the disease. So the entire, if I look back, all 14, 18 years of experience in orthopedic patients, the maximum number of patients who came to me, either whether they're coming from osteoporosis, any age group, they had one thing in common, that most of them were suffering from varying level of vitamin D deficiency. And that gave me always, we were doing just the firefighting. They came, we saw the level, we gave them the dose. Sometimes we were under treating, sometimes we were over treating. And the cycle kept on going until post COVID, when we started again, and we saw small kids coming in and walking like elderly people. Kid as young as 12 years old, that kid is not able to climb stairs, not able to play around, and the legs were bored and they were lethargic, weak, loss of energy was significant, and so many other symptoms, which made me thinking that this much of effect a simple micronutrient can do to the body, that there has to be something which should be done not just at a clinic or a hospital level. It has to be a mass education program, going out and reaching out to the maximum number of people. So that was the thought process with which post COVID we saw so many pathological fractures. We saw osteoporosis rising above the roof. We saw DEXA scans going as low as -8 or 10 in elderly and postmenopausal women. So all these parameters, and of course, not just the bone part. When I used to go back to my pediatric colleagues or physicians, even the gynecologists, they always came back with startling revelations that the moment they gave vitamin D to a infertile couple, they conceived within no time. And likewise, the immunity parameters changed drastically. Cardiovascular health also improved. So vitamin D has got many more roles apart from just handling bone and joint metabolism. So that was the thought process with which we started. And I never knew that how can I reach out to the entire Indian population. I mean, we cover more than 5 continents if we put the population together. But there has to be some way or mechanism. That's how we approached ICRIAR. And I must tell you that the brand value equity of the institute, as well as the leadership, what Dr. Arpita, I have been meeting her in last 1 year. The way she has steered the program development of this policy document, and also reaching out to each and everyone, not just, it's just not an opinion of a clinician or a researcher or somebody from the policy maker background or from the industry or from the startups world. It is a document which has taken opinion from each and every stakeholder, which can really affect the vitamin D education, distribution, mass production, cost optimization, and of course the diagnostic part, which becomes very critical when you really want to see the load of the disease. So all these parameters, I think, are very well researched through a lot of secondary data and a lot of multi-stakeholder meetings, face-to-face meetings, and meta-analysis of various documents prevalent on the internet. And while we were going through, one thing which really made us thinking, that fortification, which overall seems to be a straightforward thing, but this it has got a lot of pros and cons. And I saw some data of a few countries, like, of course, European countries like Sweden, Finland, and so many other had already mandated fortification of vitamin D. But something which actually made us proud of our loveliest and neighbor, like Pakistan, that also has mandated vitamin D fortification, and countries like Ethiopia as well. So there are a lot of examples across the world where the government has taken a lot of initiatives to make vitamin D, an essential nutrient, and reaching out to the entire population through various distribution networks. So India has got developed so many networks across supply chain mechanisms already existing, just rightly pointed out by Arpita ma'am, that those things can be utilized. We don't have to reinvent everything. It's just that we have to, go back to the policymaker, go back to the government to convince why this nutrient is so important, and why it should go back, to the distribution network, and how we can expand the distribution, how we can reduce the cost, how we can make it more plant-based and yet cost-effective, how we can reduce the cost of diagnosis, and also the distribution, and ultimately reaching to the last mile by efficient distribution network already available in the country. So these are the various aspects which have come out of this report. I'm sure this is the last day of our 1 year long exercise, but I think that's just the beginning of what best we can extract out of this report, and go to the government and try and make some difference, just as we have done in the past, whether it is smallpox, whether it is polio vaccination, or whether it is, very recently anemia Mukt Bharat, and so many other campaigns which have shown great success once the mandate from government is there. I'm sure the current political scenario would be favorable for such a campaign. It's just that we have to be more scientific, we have to be evidence based. Of course, this recent study which is going to get completed and come out with some data, the Sampada study, that's also going to support the cause which we have started with. So with these thoughts, a lot of details have come out. I'm sure Dr. Arpita, once she takes up, it goes into the detail of the report, and once you have the copy, you'll find out how things have unfolded, and so many other aspects which, as a clinician, I didn't know. I'm able to now, with more confidence, go to the community and try and help in whatever my individual capacity. And through this report and through support of all of you from various backgrounds, I think we can make a difference at a national level and create an example where such a large population can also get rid of this deficiency with a concerted effort of all of us. Thank you so much.
Thank you so much, sir. Like I said, we are again privileged to have Dr. Raghu Arkal, Deputy Director General, Ayush, Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India, who has joined us online. Sir, I hope you can hear us and would
Yes,
like you to please address the gathering. Thank you so
thank
much.
you very much. Thank you very much. Uh, I am delighted to learn that ICRIER is deliberating on a roadmap to address vitamin D deficiency in India. Specifically, as far as the traditional medicine sector is concerned, Ayush sector is concerned, we are also on board in dealing with specifically the goals under the Sustainable Development Goals 3, specifically good health and well-being. And many efforts have been done in the past, actually, particularly in the last 1 decade. Ministry is actually actively collaborating with Poshan Abhiyan and many other activities of other line ministries. Uh, as far as the nutritional deficiencies are concerned, the holistic approach of traditional medical system, it is considered as a holistic approach, specifically addressing the intestinal absorption and even the wide variety of dietary substances available in different regions of the country. So how we can integrate these kind of regional variations in the dietary substances, that is one of the things that we have thought, and accordingly we have came up the guidelines for the Ayush dietary advisory for Kuposhan Mukta Bharat. So in that very specifically we address various age group, for example, whether the adolescent girls, lactating mothers, old age persons, different segments of the society, how appropriately the Ayush dietary practices can be integrated into that. So that is the one of the area which is really looking to further accentuate in the entire country. So what I suggest actually, many of the traditional practices which otherwise we tend to often neglect their impact on the human body in making very specific nourishment in various conditions, actually, that has to be given due importance. Uh, Specifically, we have done certain studies. For example, there are certain ghee preparations which can be considered as an add-on interventions to the classical other drugs to improve the vitamin D intake in the body, and also which also found to be resulting in preventing the disease condition like osteoporosis at the later stage of the lifespan. So these kind of interventions are appropriately integrated along with the physical exercise. When we speak about the physical exercise, we often mean those who are actually going to the fitness sessions in the gyms, etc. We often neglect the importance of the yoga and the Surya Namaskar, actually. So first of all, we say that there is a need of exposure to the sunlight. So why can't we integrate this exposure to the sunlight along with the practices like Surya Namaskar or Bhujangasana in the open spaces actually? So inculcating that behavior from the very beginning, for example, in the school age itself actually, so that would have more impact in preventing the diseases like that vitamin D deficiencies in the country. So I think there are a lot of avenues are available. Government is trying to inculcate the strengths of the traditional medicines and integrate into all the national programs, whether it is in the Ayushman Arogya Mandir, where we are also addressing the nutritional deficiencies through the community health officers, engagement with the outreach, whatever the outreach activities and outreach platform which is available in the community. So every aspect actually, this nutritional aspect is being emphasized. So now you may be knowing that Ministry of Women and Child Development is actually portion Pakawada is actually is going to happen in this month of April, this time period. So there also Ayush is actually appropriately integrated and it is actually doing its appropriate interventions in the community. So all these concerted efforts for addressing the malnutrition per se, as well as specifically the vitamin D deficiency can do wonderful impact on the community so that in the future we can just prevent these kind of disease condition. That is what I think. So once again, thank you all the experts and panelists who are actually deliberating this issue, and also I hope that whatever the report you are actually submitting today is also having a glimpses on the strength of the traditional medicines and the way forward also Ayush is also integrated. Thank you all.
Thank you so much, sir, for taking out the time and addressing this pertinent issue. Now, may I proceed forward with Dr. B. Sasikaran? Sir, we would really request you to shine some light on this blazing topic. Thank you, sir.
Very good morning to everyone, and I feel deeply honored to have been included in this activity of preparing this roadmap. And first of all, I'd like to compliment the authors who prepared this, Dr. Arpita Mukherjee, Dr. Ashish Chaudhary, Ms. Latika Katwani, Ms. Trishali Khanna, and Dr. Pallavi Verma. Are the other three in the audience? You can stand up so that everybody else can see. Only two of the authors are visible. Now, please give them a big hand. Thank you. Thank you. Now, as in the beginning, Dr. Mukherjee was mentioning about how in a country which has got multiple micronutrient deficiencies, one of the deficiencies like vitamin D got lost. It's simply because there are larger deficiencies elsewhere. So iron deficiency is the one which took the priority, simply because the end outcome of iron deficiency is measured by hemoglobin, which happens it's more a sensitive change than what happens with vitamin D deficiency if you're going to look at bone health as the ultimate outcome. Bone health happens at a much later stage, while already several other events actually take place because of marginal vitamin D deficiency, which we have not have enough data to convince the policymakers that this is as even greater priority probably than iron deficiency anemia. Now, recently, there are several studies which showed that in the presence of vitamin D deficiency, there is heightened systemic inflammation. And when there is higher inflammation in the body, the liver produces a protein called as hepcidin. And hepcidin inhibits iron absorption. So it appears as though if you want to accelerate the mitigation of iron deficiency, you need to also accelerate vitamin D supplementation, because the iron is not getting absorbed because you don't have enough vitamin D. Vitamin D is such a unique nutrient, or rather more like a hormone, that there's a receptor for vitamin D in every nucleus of every cell in the body. So why are these vitamin D receptors present? If you look at the receptor which is present in the intestinal cells, when vitamin D binds to the receptor, it triggers the intestinal cell to absorb calcium. So that is what we know fully. The same receptor in the osteoblast, when it gets triggered, it synthesizes bone. There are also such receptors in the pancreatic beta cells. So we did a study almost 30 years ago when we took diabetics who were on insulin, and in a double-blind randomized study, when we gave one group vitamin D and other we did not, we found that their insulin resistance came down and their insulin requirements also came down significantly. It was long before we even had the proper assays. So vitamin D is ubiquitous. It is present everywhere. And so therefore, there are several symptoms which show up as vitamin D deficiency. The commonest is the fibromyalgia. The muscle pains also are due to vitamin D deficiency. I'm sure that 90% of us sitting in this audience will have some form of a muscle pain or the other. How much of this is because of vitamin D and how much of this is because of our bad posture? I think we'll have to decide only by looking at the levels of vitamin D. Now, inflammation is now taking a very major role. Someone mentioned that during COVID, I think you said that the trigger for the whole thing started with COVID. During COVID, we found that people who had a higher amount of systemic inflammation had greater morbidity because of the viral infection than those who did not. So we called it as comorbid conditions. And vitamin D is one of the nutrients which brings down this inflammation. Now, how many of these people who had higher inflammation and succumbed or had morbidity due to COVID actually also have vitamin D deficiency? Was vitamin D tried as a therapeutic measure to bring down the inflammation? Now, these are certain areas. If we look beyond bone, we'll see a lot of things going wrong because of vitamin D deficiency. So we need to generate data on these and then tell the policymakers how serious this issue actually is. And of course, the non-communicable diseases is now undergoing major thrust and a lot of concentration and inputs from the government. And if vitamin D sufficiency will bring down at least 10% of the prevailing NCDs, particularly metabolic syndrome, can we delay the onset of diabetes among the young people in this country? So there are several other areas of interest in vitamin D, which not only for research, but also in the area of policy. And there was a mention by the online speaker about adequacy of sunlight. In fact, if you look at the dietary guidelines and RDA, which NIN is to bring out every decade, somewhere in the 1990s, I was associated with the 2010 one, where we brought in around 400 IU as the RDA. But prior to that, the RDA book used to say that since sunlight is the source for vitamin D synthesis, there is no need for any specific RDA for vitamin D. And in case of elderly and people who are unable to be exposed to sunlight, a measly 200 IU was recommended at that particular time because we had no data. Now that we have data, the RDA has been revised and then it has gone up to somewhere from 400 to 600 units. So now the sunlight, if we have bright sunshine, this country is bathed with sunlight. Yes, I agree. But the country is also covered by suspended particulate matter. Every day you see the AQI values, it is about 20 to 100 times more than what should be the normal limit. With so much of suspended particulate matter, the UVB rays will get reflected out. So even if I stand out in the sun right now for the next half an hour, I would probably get only UVA burn of my skin than synthesize even a microgram of vitamin D. So such is the situation. And vitamin D is also a lifestyle disease. And so it is related to the way we eat, the way we dress, and the way we stay inside enclosed rooms. And most of these glasses are impervious to UVB rays. So where do we get the sunlight stimulation at all? So we need to rethink all this. And then for immediate requirement, of course, is fortification. And fortification of several nutrients are now required because they interact with each other. The day we understand the interaction between micronutrients, we won't be pushing single micronutrient supplementation, fortification, and we need to have more. And lastly, when it comes to regulation, when I was involved with the FSSA, Madam, you were just discussing about the vegetarian versus the non-vegetarian thing. This actually has come as a bit of a pain for regulators. For the simple reason is I have always said that if a nutrient is in its purest synthetic form, it doesn't matter where it came from. Ultimately, what you're consuming, there is no animal cell, there's no animal DNA, just a chemical molecule. Why tab it as non-veg at all? I don't understand. The FSSA people almost understood what I had to do, but then there were some reservations that religious groups are there, and so we should try to convince them. A chemical cannot be vegetarian or non-vegetarian. Ultimately, it's a pure chemical form. So if that part of it is removed, we could probably have better fortification with D3 rather than D2, even though D2 is efficient, is not as good as bioavailability as D3. And D3, of course, is more effective. You're right, sir. So there are several such issues we need to discuss. So this document probably will trigger off a thought process among the policymakers and also look at the economic issues also. Since there's an economist sitting here, a study which was done in UK on vitamin D fortification found for every £1 invested, the economic benefit was £10, which is roughly 10 times, which is quite a good investment. And I think we should look in terms of that as well, with that the human efficiency can also be triggered if we have sufficient amount of vitamin D. So thank you again for this opportunity, and thank you, ma'am, and good luck to both of you.
Thank you so much, sir. It is now time for the much awaited release of report, Roadmap to Address Vitamin D Deficiency in India. And for this momentous occasion, to begin with, I would like to welcome the visionary who laid the foundation of Akash Healthcare and turned it into a name of hope and healing. A teacher, a mentor, an entrepreneur, a leader, Dr. J.C. Chaudhary, who has spent over 5 decades inspiring minds and transforming lives, first through education and now through healthcare. He is the founder of Akash Educational Services, one of India's most trusted names in coaching for medical and engineering aspirants. Under his leadership, the brand reached unparalleled success and became a household name. He later extended his vision into healthcare by establishing Akash Healthcare, a state-of-the-art institution committed to world-class treatment and compassion with ethics. A Guinness World Record holder, a celebrated numerologist, and a recipient of several awards for excellence in education and leadership, his accomplishments span across the industries and inspired generations. With unwavering ethics, dedication, and an unshakable belief in his mission, he continues to guide Akash Healthcare to greater heights, impacting lives not only in India but globally. May I request JC sir to please come on stage? May I request Ashish sir to please welcome JC sir with a small token of our gratitude. May I request the dignitaries on dais to be with JC sir and MD sir so that we can, I will, of course. And also requesting all the co-authors of the report, Ms. Latika Khatwani, Ms. Trishali Khanna, and Dr. Pallavi Verma to please join us on stage for this occasion. May I please request all our second session panelists and the dignitaries to please join? Yes, ma'am, that will help. Thank you, everybody, and many, many congratulations to all the authors. So, yes, sir. We have already heard her speaking. She asked me not to say this, but I really want to. A thinker, a researcher, and a guide who bridges the knowledge and policy. Our very own Dr. Arpita Mukherjee, Professor ICRER, to please present the key findings of this report that we've just seen launched. Ma'am.
I need somebody to set up the laptop. मेरे को सब कुछ सुन सकते Thank you. Huh? Yes, you. Abhi. Okay. मैं बोल दूं क्या? Dr. Chaudhary, please come on the stage. Again, I would like to give a little bit of a setting of this report as we go through the presentation. First of all, ICRER, we believe in cross-thematic research. And in cross-thematic research, it doesn't mean that two economists sitting across two themes doing research. It means that we really go cross-thematic, where you talk to experts who are in different works of life. And here we have been able to put forward a research where a persons in medical professional field is trying to work with professionals in economics. And what we are trying to do in this particular report is to bring a health impact, economic and health impacts of a disease is very well studied. And the way they look into the disease is they look into the direct and indirect health impact. It can, lead to your death or to your loss of productivity because of a particular disease. And as a country, it is a big loss. And why is it a big loss for a country like India? India has the world's largest population today. We have kind of superseded China. We are also food secure. It's not like we have a food security issue. And if you look at government documents, they talk about nutrition security issue. So we are moving away from food security into nutrition security. And in the nutrition security, we are finding that vitamin D deficiency is today kind of attacking a lot. I'm not going by the numbers that you see, 1 in 5 or whatever, 60%, 70%, 80%, but there is nobody who says it is 50%. So it is kind of encompassing a very large section of the population, which is threatening their productivity, because you have heard Dr. Shashikaran talk about that, you feel weak. You feel weak, your bones can get damaged, so it is impacting the productivity of the workforce. India is also a country where if you look at the current union budget, you will see that the healthcare sector, expenses are very low. You depend upon private sector for your healthcare. Government healthcare sector expense is low, but within that low expense, government has a lot of priorities to address. No tobacco, no alcohol, and all these priorities today are laid down by regulations of the World Health Organizations, UN SDG goals, and other things. And in this entire priority, somewhere the micronutrients get a miss, and within the micronutrients, specific components of micronutrients get a miss. In this context, what we try to do is to actually look at how we move around within the limited budget to create a roadmap to address the deficiencies by 2030. And we also look at what other countries, what kind of initiatives have been taken, where there are success, where there are not success, what is the problem of replicating them in India. And then we also try, this is just a beginning. We would like to seek a lot of stakeholders engagement in as we move around in the report. Few things to be said that we could not have done the report with many of the experts who are sitting today here. They will be our panelists. They have given us valuable suggestions as stakeholders as we walk through this report. We would have a special thank you to Dr. Sashikaran and Simaji, who painstakingly read through each line of the report and gave us comments. We would like to thank ICMR NIN for giving us the opportunity. They read through the report. And now I am very happy to say that when they get a parliament question on vitamin D, they kind of send it to us. But some of them are so medical that I can't respond. But happily, it is directed towards us. So I think there is some weight in this report. And not, last but not the least, to Kulpreet, she always brings the most difficult thing to be researched on into my plate and gives the feeling that all is well. Okay. Yesterday also, when I was panicking that there is a ministry meeting today, what we will do, her approach to the problem was all is well. Now, the point that we go into is the report in itself. In the report, what we try to do is we give an introduction. We try to make it as simple for the layman, yet complex for the medical fraternity and simple for the policymakers to understand. The report has the introduction. It goes into the reasons. Then it talks about the global best practices, what is happening. It talks about the problems in India a little bit, then the governance structure and the challenges, and some of our recommendations. We don't kind of display the entire report because we thought that we would get some royalty out of it. But just to give you some feeling, the report is actually based on secondary data analysis, reviews, and key informant interviews. And that's the route we take because big health surveys are yet to come out with their data. But I'm also very proud and very happy that India has now decided to do this ICMR NIN Sampada survey at a 5 years interval. And I think, the next sequel of the report may have a better data than we struggled with. What did we did different meta-analysis will come out with different results depending upon your coverage of the data, the period that you take, the literature that you look at, and all. Given all of that, what you absolutely end up in that the deficiency is high. It is high. There are regional variations. There are certain prone groups within the deficiency, and the prone groups are not different in India. Children, pregnant women, elderly. This is where the deficiency lies globally. Okay. And then you are yourself somewhat responsible for your deficiency because of the indoor, apathy to sun, etc. Now, sir has very nicely explained the sun exposure. Now, you also have, extreme weather condition. In Delhi, if we tell somebody to sit in the sun at 12 noon, the children will faint if they are put in the sun. So there are sun timings, summer, winter timing. So it is, India has a multiple climatic zones, and that makes it very difficult to get a pan-India policy on sun. Diet is again a very important factor because vitamin D vegetarian diets are expensive. It is not cheap. If you talk about mushroom is vegetarian, it's not like everybody can afford a mushroom. So even meat is expensive. So diet, if you talk about salmon and all of that, the palate is expensive. Cultural and social factors, we want to be fair, we don't want to expose ourselves to the sunshine. We have you wear full clothes to even your schools when you are in higher classes, and then the pigmentation of our skin also makes it difficult to get the sunlight. Now, international organizations are coming out with essential mineral rich food fortification. They are talking about deficiencies, how to address that from your childhood days. Countries have also come out with fortification. The entire fortification story is that it was developed mostly by those countries like the Nordic countries who had limited sunshine. And then, even in countries like Iran, they had to come up with, because they had lot of clothing and women started facing the clothing related issues. But when we come to the core part of the storyline, the important part is that it is a mix between your diet, your lifestyle, your clothing, your ways of happening. So ultimately the entire thing is that it is have to be a awareness building across the people. And therefore I think the logo is very important. Be aware and then get into a habit. Now, what have we done so far? We have done quite a bit of things. We have actually fortified oil and milk. First, it was mandatory, then it was voluntary. We have Dr. Nair with us in the fortification committee. She knows much more than me. I would not go into the details. She will give you the details, what has happened. Then we also have this, we have a flip-flop in the essential list of medicine. Sometimes D2 is inside, sometimes D3 is inside, sometimes both of them are inside. Now, the essential list of medicine is just an indicative term. Because when it is under the essential list, it is expected that it will be cheaper. Yes, it is cheaper, but we have put in a GST of 18% on it. If it is essential, why do it have a high tax? Okay, that is the thought process we need to think about. Secondly, we also need to think about that we are a large manufacturer of vitamin D. So it is not that we need to really think about imports, burdens, and other stuff. We have our domestic capabilities. We need to help with lowering of the taxes for the medicine to reach the consumers. The other thing that we need to think about is what is our requirement. The requirement actually vary. Kids have a different requirement, pregnant women have a different requirement, and therefore we need to be, at least those who are aware among us has to know what is my requirement and how I am getting the requirement. One of the core problems in these kind of supplementation programs are that if you give it to the poor without the awareness building and stuff like that, maybe you distribute vitamin D supplement through ASHA workers or others without the training, they are overtaking the doses and there can be an incidence of a vitamin D toxicity. So the community level programs also have to go through a very rigid process of checks, balances, can be done through the community health center. So there were many programs that were launched. Some had faced a lot of issues in connecting to the people, getting it through, explaining to them whether it is vegetarian, non-vegetarian. In Gujarat, there is a high sunlight, but there is a high incidence of vitamin D deficiency. It is very difficult to explain to them that all tablets are not a non-vegetarian tablet. So there are cultural issues. So let me actually explain that one good part of the government agencies which you actually saw today is that when it comes to vitamin D deficiency, whether it is a traditional medical practice or a modern medical practice or diet and nutrition, all these segments are coming together. So there is I would say, among the expert, there is not a major knowledge gap and not a major deterrent to talk on this subject. But experts tend to address the subject very fragmentally from their areas of expertise. So some will talk about what, IQ should be there. Some will talk about, what should be the measurement criteria. Some will talk about when the sun should be exposed. Nobody talks about it on a solution oriented approach, and that is something probably there is a need for a government and multi-stakeholder platform and collaborations. Because when you build a multi-stakeholder platform and collaboration, then you get all the people together, you also get a funding together for this cause. And the funding together for any cause comes at a step-by-step process. For example, the government announces a logo or a process like, nutrition mukt bharat or vitamin D mukt bharat or anemia mukt bharat. Then for that cause, companies and others can put in their CSR funding. Then government can have a scheme, but the main funding is a collaborative approach of different players to actually fund through that scheme. And when they work together, that is where you reach a success. You can, and especially you need this in India, because India is also a quasi-federal governance structure with a distribution of healthcare between the center and the state. So there you need to have a framework. And when we interviewed the state government said that, what you need is a kind of a micronutrient committee kind of a thing set up. Either ICMR sets it up or the Ministry of Health set up a micronutrient committee which works together to discuss, because there are different government agencies doing different government programs for nutrition. Ministry of Education will look after portion. So you have to bring somewhere all of them together under one roof. But when they come together, what happens? When they come together, then they find there is nothing to discuss. Therefore, there has to be some kind of a comprehensive vision document. Even if this document gives this is kind of a putting everything together document. But what the government needs to do is to pick from this document, prioritize and clearly put down how it is going to achieve the targets. And there has to be targets. Without a target and with what you want to achieve, how much is the expense, you cannot have a budgetary allocation on a subject matter. Then you need to look at the gaps, and the gaps can be in food fortification, food supplementation. Gaps can be in testing and treatment. Now the food fortification, I'm just giving you some examples of the gap. In testing, if you're already doing testing if you're already collecting blood, which you're doing for iodine deficiency, anemia deficiency, your cost is much lower. Then you again launch a scheme for a fresh vitamin D testing. So you have to think through how do you plan your testing. In case of food fortification, the problem is like this, that now milk and oil is allowed. Because milk and oil is allowed, many of us actually suggest puri sabji de dete hai in food to children. Now puri sabji is not really a healthy food. So there is another healthy food versus non-healthy food movement. Milk, although fortified, a very good instrument, is very difficult to give milk in midday meals. So we need to think what can be given. If khichdi is easy to give it, can we really fortify? And can we fortify less than the amount so that the khichdi has that fortification, yet we don't have the intoxicity? So this is a complex discussion that government needs to think about. There are success stories in India. When we did the study, we found there are success stories in India, but it is not rising. The other thing that we also found is that there is also a lack of awareness. What is veg? What is non-veg? What is my diet? What is my dietary challenges? And all of that actually requires some kind of a, some kind of a awareness building on your diet and food habits. And I must say that ICMR NIN dietary guidelines is actually quite good. It can be taken a step forward as you get the data in place. But the entire guideline is that we don't have a government awareness program. So they try to make it aware the way they can. So the educated community talk among themselves. We don't go to the masses. So a ASHA worker in a village should be able to explain to a villager what is a vitamin D deficiency and how the villager will know that he or she is deficient. Given that Indian survey shows that the deficiency is among the Javans, the deficiency is also among the farmers. So it is very important to explain to all groups that, for your purposes, you may be having the deficiency because you are not doing 1, 2, 3, 4 things right. So what we try to do, we try to actually talk about a multi-stakeholder cooperation and platform creation to make a vitamin D Kuposhan Mukt Bharat. And sometimes it can be even a virtual platform. This is not in the report. I don't give the report solutions because I think that, somebody should read the report. But I'm just thinking, and maybe Seemaji, for you to take forward, that should we not create a multi-stakeholder platforms where people can post their common, common understanding, common literature, common write-ups on vitamin D, and can have a debate and discussion. I believe that yesterday another vitamin D report was launched. More the better. But many times what happens is that many a times the journal, people write in journals, right? Health experts write in journal. Accessibility is an issue. I think there should be a common platform for knowledge sharing. So that is one thing which we need to think about. Then there should be a common platform to bring the multi stakeholders together, interministerial partnership and coordination. And that is sometimes the industry cannot make it. It is very difficult for the industry, and it is very difficult for the industry to go to each ministry separately, give a copy of the report, and with no bharosa that the next day the person may be transferred to Film Federation of India. So there has to be some kind of a balance in which this movement moves forward, and that is something we need to think about. The last is not but least is that, you have to think about when the government programs happen, whether it is essential list, whether it is fortification. We need to think 5 years in advance, and every time we think about making a program work, there will be certain kind of opposition. There may be opposition from food industry for product reformulation, mandatory versus voluntary. There are oppositions, and globally there has been oppositions, and it is therefore it is very important to have a food industry partnership, pharmaceutical company partnerships. You have to bring together the partnerships. And it is always good to move forward when and when your oppositions are your partner rather than facing the opposition. So that's kind of my suggestion. Rest of it is here. A partnership, collaborations towards the common goal of vitamin D Mukt Bharat, both in India. Then we also need to create a forum and platform where we interact with similar agencies and embassies of the other countries, where we have a thought leadership, and we can also have some international agencies and thought leaders bringing in their policymakers from countries like the UK, Finland, Iran, and many other countries you may think about who have done successful programs. Maybe they have faced a problem. We can do some webinar series on that. So these are some of my ideas to actually get back to a theory where we can create a network both internally and beyond India to make this kind of a global campaign. Many things that we do first in India becomes global success stories, and I am very sure that if we do it right, this will also become a global success story. Thank you very much. Have a question? Okay, so we can take 1 or 2 questions.
Okay.
Just sir, 1 minute. First introduce
Yeah, I'm
yourself.
Dinesh Sharma. I'm a journalist. I'm not a doctor, but I keep reading medicine, especially I have read Harrison's medicine. So I have the whole discourse is about the vitamin deficiency. But what about the vitamin D toxicity? Nothing, I have not read the whole report. But this issue should be dealt with. How to make people aware about the toxicity of vitamin D? This is my question.
Can I reply about the toxicity? I'm Professor Haq. I'm involved with vitamin D research for the last 20 years. As far as the toxicity of vitamin D is concerned, it is a beauty of vitamin D that there is no single report of death is reported in the literature because of vitamin D toxicity. Okay. There are symptoms of toxicity of vitamin D like fever, lethargy, vomiting, loose motions, but they can overcome by simple treatments. Okay. And toxicity, how it comes, toxicity, you want to know? Yeah. The optimum levels of vitamin D that one should have is 100 to 150 nanomole per liter or 40 to 80 nanograms. That
Final discussions will happen. Let me answer the question. That part which you would like to explain to him about the toxicity, we will take it up during the tea. We would like to, we have understood your point that nobody dies. Let us answer this point and then we will give you an opportunity to speak if we have time, because we are running out of time. Anybody else have any questions?
okay, thank you.
One clinical thing what Jesus mentioned, that there is no death reported. So the only way that death can happen is iatrogenic, induced by the clinician. We have had one report where a patient was given an injection on a daily basis for 21 days. That's very high abnormal intoxication of vitamin D. Such things can go out of the roof and they can lead to a severe morbidity or mortality. Otherwise, it usually causes some symptoms which can be managed and reversed with due treatment.
And may I answer your question that whether we have covered toxicity? Yes, we have covered it in the report. Secondly, is that the toxicity, because of the toxicity, whenever the government is putting anything in the public domain as a fortification program, they are always keeping the limits lower. It is not like they are going for the highest limit. They are ensuring the lowest limit. But what happens in supplementation programs, and it has happened in some of the countries, including India, you give a sachet, you tell them that you use the sachet over a week, they use it in one go. So it is a awareness issue, not a program issue. Okay, so therefore we have mentioned that awareness has to be built. One last question, please.
Yes, my name is Dr. Raja Singh. I'm a postdoctoral fellow in School of Public Health. My question is two questions, very small. The issue with respect to the oil intake, the cutting of oil intake that is being pushed. Number two, there's an issue of the regulation in schools that the added saturated fat has to be reduced and the trans fat has to be reduced, and that's good. But when you're buying something, it's very difficult to only have HDL fat, like non-saturated fat to be in foods which are commonly available. So my question to you is, with the whole hysteria around reducing fat, how do we make sure that it doesn't affect people, absorbing vitamin D properly? That's my question.
Good. Your question is probably best answered in the next session, but let me give you my point of view. Basically, when you talk about what is high, what is low, and HFSS food high in fat, sugar, and salt, you need to have a definition of HFSS. India is yet to come out with that definition. That is point number one. Point number two is India has banned trans fat. So that bad fat has already been banned. Point number three, yes, we are talking about not having oily food, not and all of that. So therefore, the oil fortification is, you cannot rely alone on the oil fortification or the milk fortification. Also, from the point of view that we have a huge informal sector in this, like milk and oil, you can even have it milk from your own cow, and informal oil mills are there in the villages. So therefore, you need to think about many products fortification. Having said that, this is a complex subject in the country. Food fortification also requires industry to reformulate. It is also in other countries, subsidies are given linked to food fortification fortification. So it is very complex. Whether you fortify iodine, calcium, vitamin A, D, everything together, you put them separately. How do you communicate fortification? This is very important, and I want to mention that because in India there is a choice logo which says you see fortified juice. You go and do a Google search, you will get fortified juice. FSSAI has not either given voluntary or mandatory fortification to that. So there is a choice logo. You do it by choice or you do it by government program. So these are things we will debate and discuss in the next session.
Thank you.
I think I have covered everything. Okay.
Thank you so much, and thank you everyone for engaging the session more. I would like to conclude the session, I would like to invite Dr. Ashish Chaudhary for his closing remarks.
Well, that's the end of the first session. And at this, I would like to thank, starting from ICRIER, which has been very pivotal in drafting this report, Dr. Arpita, Latika, Trishali, Dr. Pallavi, all the co-authors who have contributed significantly, all the institute leadership, Dr. Seema Puri, Dr. Sasikaran, and Dr. Nair, and many other policy makers and industry speakers. They have contributed significantly in drafting this report and reviewing and giving their valuable comments and inputs. I think once you go through the report, all the things which have been talked about, even related to fortification, the confusion, and what is the present status, and how we can tackle this at a national level, I think all these things will get more and more clearer. And wherever we can collaborate to make it a reality, to reach the last mile in the country, I think we are all in for that. Thank you so much for patient hearing.
Thank you so much, sir. May I request Ms. Latika Khanna to honor sir with a small token of our gratitude. Thank you. And this is the end of the first session for the day. We will have a short tea break around 15 minutes, and we will reassemble here by 12:15, right? 12:15, everyone, please.
चेंज कर दिया चेंज कर इधर लो ये लगा ग्लास है ग्लास लगा 6 ग्लास सीनियर यहाँ तो बैठे कुछ दिखेगा नहीं ठीक है नहीं तो आप बताओ ये इससे बैठे कैसे बैठेगा देख लो
May we have everybody on seats, please? Yeah, may I request everybody to please take their seats? So good afternoon, everybody. Welcome back. May I request everybody to please take their seats so we can start the second session? So once again, welcome back, everyone, to the second session of the day, Roadmap towards Vitamin D, Kuposhan Mukt Bharat. I would like to invite the panelists and the moderator to kindly join us on the stage. May I request Dr. Seema Puri, Professor, Retired Institute of Home Economics, University of Delhi. Ma'am will be moderating this session for us. Welcome, ma'am. And now for the panelists of this session, Major General Retired Dr. Raman Marwa, ex-Additional Director, INMAS, and President, Society of Endocrine Healthcare for Elderly, Adolescents, and Children. Welcome, sir. Dr. Srimao Nair, Professor, Center for Public Health, Navrachna University, Vadodara, currently serving as Scientist and Chair, Nutrition and Fortification, FSSAI, and Working Committee Member of Codex. Welcome, ma'am. Ms. Ruchika Chug Sachdeva, Nutrition Lead, India Country Office, Bill Gates Foundation. And Dr. Supreet Kaur, Head Policy, Programs and External Relations, Global Alliance for Improved Nutrition. Welcome to all the panelists and moderator. May I now hand over the mic to Dr. Seema Puri. She will take away the session from now. Somebody help with the mic, please. Yeah. So we have loud enough. Yeah. Good afternoon, everyone, and welcome. So good afternoon, and we have the mics here on everything. Welcome to this panel discussion, and we've had a very interesting session in the morning, and I think most of us are very clued in about vitamin D deficiency. But let me tell you, having been working in this area for a long time, it's still, we are just unraveling the mysteries of vitamin D. So there's a lot more that we need to know, a lot more about the situation in our country and how we're going to deal with it. So we are very honored to have a very esteemed panel amongst us, with all the panelists having immense experience in this area. So without much ado, I think we will proceed to the session so that we have more time for discussion and deliberations. And taking off from the report, which is the roadmap to vitamin D Kuposhan Bharat. Our moderator, we have already been introduced to the speakers, so I won't take much time in trying to tell you what they're doing, but let me assure you that they have the authority and the experience of working with vitamin D for many, many years, and they're able to rightfully address the issues. So to start with, I'll start with Dr. Marwa, because Dr. Marwa is one of the pioneers and has been doing extensive work in vitamin D deficiency and detection amongst all age groups in our country, as well as also the mitigation of vitamin D deficiency and the strategies that should be there. So I would request you, Dr. Marwa, if you could share your key findings or insights as to why this problem occurs and what is the extent of the problem.
Thank you, Seema. Good afternoon, ladies and gentlemen. So you've been hearing since morning that vitamin D deficiency is a widely recognized public health issue world all over, including India. And this, we have shown over the last 2-3 decades that this is an endemicity of vitamin D is huge, and it occurs in all age groups, right from newborns, infants, school children, pregnancy, lactating mothers, adults, and elderly. and therefore, and also common in both genders, and therefore needs urgent attention. Now, why vitamin D is so important? Because it has a profound effect on your growth and development during childhood, and also it takes care of your bone health in adults and elderly. Now, recent meta-analysis of vitamin D deficiency has very clearly shown that there is association of not only vitamin D deficiency with bone health, which is well established, but also it is associated with several systemic disorders. However, the causation and the prevention part of these systemic disorders with vitamin D supplementation is still contentious. So therefore, what we know is that it certainly is important for bone health, but the meta-analysis, there is a contention with regard to various systemic diseases. Now, why Indians are most susceptible to vitamin D? When we first worked on vitamin D deficiency in school children in early 2000 and showed that 90% of these children had less than 20 nanograms, and the genovirum genovelgum, that is knock knee and bow legs, were common in almost about 10% of healthy children, which goes to show that how severe was the problem. And then that was the time when I published this in American Journal of Clinical Nutrition. Before publication, everybody said that there is a mad doctor saying that there is vitamin D deficiency in this sun-drenched country. And I had to face a lot of problems. Then we had to show it in all age groups, pregnancy, and all this over the decades. But why is this more common in Indians is because one is the limited sun exposure. Now, either it is because of your lifestyle changes. None of us go out during the morning time between 10 and 3. We don't really go out of our rooms. We have cultural problems. Ladies tend to cover themselves, don't expose their bodies to sun. And then we have vegetarian diets. We are highly pigmented. We have a lot of melanin content, which prevents synthesis of vitamin D. Atmospheric pollution is huge. Delhi, for instance, is the most polluted city. And we have shown that in winters, Delhi does not synthesize any vitamin D. We expose children for 1 month every day between 11 and 12 to see what is the synthesis of vitamin D. There was no synthesis during winters, probably because of smog. The penetration of the UVB rays was not reaching the Earth's surface. Before doing this, we had shown that UVB rays across the country, the maximum UVB radiation is between 11 and 2 p.m. That's the best time when the sun is right ahead, perpendicularly the least pathway to reach Earth's surface. So we measured UVB rays of 290 to 315 nanometer wavelengths throughout the day to show. And what we also showed that the maximum UV radiation was in summers, followed by monsoons, and then by winters. So the best time is between 11 and 1. That's how we expose these children between 11 and 1. In summers, when we exposed them, the rise was about 3 to 4 nanograms. It still did not achieve the normal levels. See, there is a lot of problem when you will see this report. The earlier definition of vitamin D deficiency was anything less than 20 nanograms or 50 nanomoles per liter was defined as deficiency. But now Institute of Medicine has defined that less than 12 nanograms per ml is deficiency, 12 to 20 is insufficiency, and more than 20 is sufficiency. Whereas American Society of Endocrine, this thing tells you that more than 30 is the cutoff for sufficiency. And they also say that if you want extraskeletal benefits, your level should be between 40 and 60. We have our personal experiences with high dose vitamin D. I'm not going to talk about it today. But the point is, how do we deal with this problem now? That is what we have been talking since the morning. See, you have to have a multi-pronged approach till we come out with mandatory fortification. Now, the multi-pronged attack will be either you take food which contain high vitamin D, which is something like cod liver oil, fatty fishes like salmon, mackerel, tuna, All these fishes, these are cod fishes which have this. None of us take cod liver oil. Maybe in childhood, our parents used to give us little cod liver oil, but nobody, and in army, we used to serve liver as snacks, which is not seen anymore, I think. We don't eat liver, we don't eat fatty fishes. So the diet, me and Seema has worked on the intake of vitamin D through diet. We did not have dietary values of vitamin D in our foodstuffs. So we used American agriculture data to say that the maximum consumption, maximum intake of vitamin D during by a person is between 60 to 100, maximum of 100 IU per day. But now when we have evaluated all the Indian foods, we never found vitamin D in any of the foods except for one or two small fishes like putti and others, which has little vitamin D. So diet does not provide you, especially because most of us are vegetarians, so diet does not produce. Exposure to sun, we have already worked and said best time is 11 to 1, half an hour is good enough, 15 to 30%. It will raise in summertime for 3 to 4 nanograms, but does not take care of fully because of several reasons which I mentioned earlier. Coming to supplementation, which is very, very specific because you can change the dose. But the problem with supplementation is, can you take supplementation throughout your life? Every day you take a supplement, or once a week or once a month, and then it is expensive. So the only solution which I suggested, because when we supplemented vitamin D in school children for 1 year, after 3 years when I went back, the prevalence of vitamin D was the same. The parents do give milk, but they do not supplement vitamin D. The last is the fortification. We did 2 studies. That's how the Food Safety Authority of India, we were together when we brought in this government letter saying that we must fortify because that's the only way everybody will consume or have intake of vitamin D that is milk and oil, because oil is used by everybody, rich, poor, whosoever, and milk usually is consumed mainly by children and elderly. And why this is important for children is because your peak bone mass is formed during that time. That is the time, if you do not have adequate calcium and vitamin D till the age of 18 to 20, when you achieve the peak bone mass, after the age of 20 to 30, you start losing your bone. So it is like good bank balance. If you have good bank balance, that means good peak bone mass, by taking adequate intake of calcium and vitamin D, you may have a nice retired life if you have good bank balance. Similarly, you will not have osteoporosis or fragility factors like that. Thank you very much.
Thank you, Dr. Marwa, for a very, very comprehensive description of the entire huge, vast problem of vitamin D deficiency. And as Dr. Marwa said, that generally for any micronutrient deficiency, there are 3 approaches, which is the diet, where vitamin D food sources he's already mentioned are not so common in our diets. There's supplementation. He's talked about the pros and cons. And we ultimately come down to fortification, which is being promoted. And Dr. Dyer, being the head of the panel of fortification at FSSAI, I have a couple of questions for you. We do know that fortification of milk and oil has been suggested. Firstly, is it voluntary or mandatory? Secondly, are the recommended levels of the vitamin D fortification as given by FSSAI really effective, or will it really help in closing this deficiency gap? So over to you, Dr. Dyer, for your opinion.
Thank you, Dr. Seema. Good afternoon, ladies and gentlemen. I also would like to take this opportunity to thank Dr. Arpita and her team from ICRIAR and Anvika Foundation for this piece of work and looking into the public health aspects of this. So to the question which Dr. Seema has put forth, when we started fortifying as a major cause, we had a plate concept and we wanted to look at 2/3 of the consumption should be from people's diet. 1/3 was to be fortified. So fortification was decided based on what is that we are consuming. So oil being the best absorption medium, vitamin A and D was to come through the oil. milk was to be fortified and given to all the school children. And that's how it went on. So rice and wheat we kept for iron, B12, and folic acid. So keeping this in mind, we already had fortified salt, which was single fortified with iodine. Later on, we introduced a double fortified salt for pregnant mothers to address iodine and iron deficiency together. So all these 5 commodities were with least amount to be consumed when population is consuming, not to have any toxic effects. So that was the first concern because we were going for multiple staples and multiple levels of fortification. So we did not want to make everything so mandatory because it was the beginning. I'm talking of 2017, 2014, 15 was the discussion started. 2017, it took multiple scientific level committee meetings to bring it into Government of India's perspective. 2018, it got addressed and gazetted by FSSAI. So taking that from there, we did not have mandatory issues at that point of time because we wanted people to start fortifying. We find what is good, what is bad, how much is being coming into the public domain, and therefore that was taken up. Later on, when we found things were not moving, we went for rice fortification as mandatory in public domain, especially for school children, pregnant mothers, and we also initiated in the ICDS program and in public distribution system so that that process was like every Indian family in a day would consume at least 100 grams, 50 to 100 grams of cooked rice. So all these levels, when we are talking, we are not allowing it to go on a toxic level. So this was the first and foremost concern. The second point, when it came to oil, vitamin A and D, so we also face a lot of issues from the public, lot of voluntary organizations who go against saying that we are interested in multiple domains and we are wanting to do business with multiple countries, and that's why it is happening. So we had certain issues. We had also certain issues on premix, which needs to be standardized, which needs to be manufactured in India. So those were other concerns at that point of time. Now, almost everything has got addressed. Now, vitamin A and D in oil is there, but not mandated. It is available in the public market, but it is a continuous program with the government schemes where ICDS and midday meal are following it regularly. I hope that answers the question. Thank you so much.
Thank you, Sri. And now going to Ruchika. Ruchika, with your experience in working with public health nutrition and nutritional deficiencies, we do know that India has the triple burden of malnutrition. We have undernutrition, we have obesity, and we also have micronutrient deficiencies. We also know that vitamin D rich foods, like Dr. Marwa mentioned, the fishes and all are very, very expensive. How can the PDS be leveraged to make nutritious food more affordable, more accessible, so that the micronutrient gap is addressed?
Thank you so much, Dr. Seema. At the outset, I would really like to congratulate ICRIAR for having the discussion on this very important topic. I think most of you are aware the Government of India has been making several efforts to ensure nutrition security, and the NFSA 2013 was one major step, and in 2023 the NFSA Act was revised. Also, there were several efforts have been made in the past, I would say a decade or around 5 years back as well, wherein the whole mandate of Department of Food and Public Distribution, they've been working towards moving it from food security to nutrition security. So currently, if we look at through the food safety net program, there are 11 states which are providing pulses at a subsidized rate. There are around 6 states which are giving millets. And through the various program like ICDS, midday meal, and PDS, they're also trying to diversifying the food baskets. So there are some states which are giving fortified milk. There are some states which are giving egg. I would say Andhra is one of an exemplar state wherein for a pregnant woman, and I was traveling recently there, wherein they are giving a full crate of eggs as part of the, for package for a pregnant and lactating women. They are giving fortified milk in Tetra packs. They're giving oil, they are giving pulses. So really a wholesome nutrition to them. So the implementation is variable and the efforts are variable. But just wanted to call out when it comes to the vitamin D, and clearly called out, and also when it comes to vitamins and minerals, the key thing about micronutrients is we cannot, produce, they have to be consumed in the diet. They can't be produced except for D, which we can get from sunlight. And even if it's available, as Indians, we have a sun fleeing nature and not sun seeking behavior as it comes to, Western population. So it's really important that how we ensure the vitamin D intake through the safety net program. So government in 2016, as Dr. Nair mentioned, came up with the standards for 5 staples. For oil and milk, they formulated standards for A and D. Oil and milk are very good vehicles for A and D delivery, given it's a fat soluble vitamin. And the cost is really minimal. It's around, in milk, it's around 2 paisa per kg of milk. In oil, it's around 10 paisa per kg. So when you look at cost benefit analysis, and I think Supreet will share more data, it's really apt. In 2017, the government also introduced in the safety net program midday meal and ICDS and PDS also, to say the states can add both fortified oil and milk in their safety net programs. Again, the implementation has been variable. Some states have been adding fortified oil in the food which is given through the safety net programs and midday meal and ICDS. There is also a component of take-home ration. There also vitamin D, some states are adding as they are making that fortified blended food. So there are initiatives where government through the midday meal, through the ICDS, through the take-home ration, different state governments have been doing. What could be done is the programming could be strengthened is one area. In the PDS also, some states are giving oil, and the ones which are giving oil continue to give fortified oil. So that's another initiative. I just wanted to quickly call out is India has been really an exemplar when it comes to open market fortification for oil, wherein with voluntary standards, more than 68% of the fortifiable oil, which we are saying less than 15 kg, which is going to the consumer households or to the hoteliers, is fortified. So I think industry had made a big effort in this space. So really wanted to call out. Where I think we really need to work is one is also we were discussing about is the testing, because this is one issue which is not easily identifiable, and when the test is only done and it's severe, one comes to know. So kind of a preclinical, it's not, but it's kind of diagnosed. So I think those rapid testing kits would really help, and that's some work which we are kind of doing with IIT Mumbai is one partner who's working on it. The other is also is one to look at the levels. We recently discussed about oil consumption. We are now talking about, making it 10% lower. Again, it requires behavior change, but as we look at the recommendation for oil intake, it will be important to look at whether standards need to be strengthened, because the current recommendation is really low for mass fortification. We just say to add 1/3 to, half the RDA. So the issue of toxicity won't arise with 1/3 to half the RDA when we are talking about addition of vitamin D. So I think it'll be really important to review the mandate, look at, rapid testing kit. So if the diagnosis happens, then the treatment or, also happens. So I'll just stop here for now.
Thank you, Ruchika. And continuing with this, I'll ask Dr. Supreet, taking on what are the major challenges which India faces in vitamin D supplementation and fortification, and any ideas of how the government can take it on.
Thank you so much, ma'am. And Before I start, I would like to congratulate the whole team for this very, very essential, the work which they have taken and which actually touches our life daily, and how our lives are being basically destructed by our lifestyle issues, which I think my previous speakers have also highlighted. So thank you so much for bringing it up front and bringing it up to the level so that we can initiate the discussions further. Before I begin answering your question, ma'am, I would like to highlight some of the recent work which has been done. It's actually underpublished, so I would just like to give a brief hint that through the recent systematic survey, which review which we have undertaken, it shows that out of 21 review studies, 19 are supporting that vitamin D fortification is a very effective and the strategy to combat vitamin D deficiency, and it helps in reporting. It's reported that it helps in improving the serum 25 hydroxy vitamin D levels. And other thing is to measure the health benefits associated with the oil and milk fortification. We did a cost effective analysis. It is again a work under review. So it shows that, vitamin D fortification can avert 93,000, years of disability in the population. So that is a huge number. If we calculate in terms of cost, it's going to be huge. And further, we did a cost benefit analysis that shows that, every unit money spent on the, benefit in terms of vitamin D fortification, like in improved health, in productivity, in reduced health care, the return is around 416 units. So you can see that how effective this type of interventions can be. And already that my previous speakers mentioned that, it's a very cost effective strategy. Less than 10 paisa is the cost per liter of fortifying vitamin D fortification in oil. And also India has standards for doing it further. So the stage is set. Only thing is, the issue related is, number one is majority of people are actually not aware of that they are having vitamin D deficiency, because it is never talked about. It's not as common as, the anemia or other things. Through government programs, the awareness is being generated. This is one area where majority of the population is unaware. The other thing is lack of mandatory policies. Although the regulations are there, still vitamin D fortification falls under, voluntary space. It's up to the industries. They are doing the fortification. They are bearing the cost. They are doing it themselves through, support of various, agencies, but not further to that. And through the various systematic assessments done over the time, it is found that, majority of oil brands which are supplying the fortified oils are still not fortifying up to the level which are actually mentioned in the label. So that again sets the stage for us to discuss and talk about that. It's high time one needs to go for mandatory oil fortification. It has to come upfront for the policymakers to take a decision and go, because everything is matured. Only thing is they need to put the stamp and the process can be going. So that not only helps the population level, but also industries. If we see, if they get, mandatory type of this thing, they can be incentivized accordingly as per the government. There are set rules for the standards for testing, for pre-mix manufacturing, and all those things are set into a proper procedure which can be fall in a place, and then the whole machinery or mechanism can move in a way so that quality products which they claim to be fortified can be available to people for their consumption. I think this further ensures that, through PDS, although fortified oil is available in various states, then we can say that quality fortified food is, or the oil is available to the masses for their consumptions. And to add, I think it is very important to encourage the innovation in terms of public-private partnerships. Not only certain agencies, it has to be work of the research institutes, of the work of local bodies, government agencies to come together to formulate and develop the low-cost solutions to make the premixes, to make the testing standards, so that, state food and drug administrators have certain type of kits which are available, which they can go and go for testing, so that on the spot checks can be done for effective fortification which is being done. I think I answered.
Thank you. Thank you, Supreet. And I think that's very, very valid. Coming back to you, Dr. Marwa, taking on from what Supreet has said about what all is being done. But I feel what are some key policy measures that can be taken in advance? Can it be a wishful thinking that we have? And some of the issues may be like screening. You know, how do we screen for vitamin D at a cost-effective way? Because they just mentioned that there's a very high cost of testing. Secondly, I remember you spearheaded the noon assembly movement in schools. Are there any awareness creation or school movements where we can, you know, really start from a very young age to try and overcome this deficiency? So any suggestions you have or wishful thinking, I would say, to, you know, for measures to combat vitamin A deficiency, which the policymakers could really take note of?
Well, there are no shortcuts to measuring vitamin D deficiency. The best method is LCMS method, which is not being practiced everywhere because it is expensive. So we usually do chemilucent or electrochemilucent methods. Now, the problem with this country is what is the normal level of vitamin D? So, you know, you can't take a decision for the country unless you are very certain as to what are the normal levels. And all of us are still struggling to define what are normal levels of vitamin D. Well, Institute of Medicine defines less than 12 as nanogram, which I mentioned earlier. And why I say so is that is apt is because most of the cases of clinical rickets have been seen with those who have vitamin D less than 10. So to play safe, 12 seems to be a very good cutoff to define, because most of our earlier studies are saying 20 cutoff and things like that. Now, there is one paper by Priemal from Germany where he says that those who have more than 30 nanograms on bone biopsy, you don't see any osteomalacic changes. So 30 should be cut off. And so does the American Society says that the calcium absorption is maximum at that level. The PTH is lowest and the bone mineral density is highest. So that's why they take 30 as the cutoff. Institute of Medicine takes 20 for bone health as the cutoff. So we have to decide. So when you fortify, our major objective should be that all Indians should have at least 12 nanograms of vitamin D or 25-hydroxy D in their blood, so that we don't have rickets or osteomalacic changes. It's very shocking that we still have so many cases of rickets across the country. Now, second, your question was that what are the key interventions for successful fortification? Is that the... So, yes, besides, now when we thought that we with NCRT, FSSAI had a program, which I think you were also involved, we had thousands of children whom we were addressing, and they were having their games during sun time, and nothing happened. They were there for 1 hour playing around. And so what we thought was that we could propagate noon assembly. So instead of morning assembly, when you don't synthesize any vitamin D at 8 o'clock in the morning, so if you can have noon assembly for about, say, 15 to 20 minutes between 11 and 1, so, or the break time 11 to 11:30, which is usual break time, I think some benefit will come at least in summers and monsoons. It may not be in winters. So noon assembly is one. And you'll be happy to note that 2 schools who had switched over to salwar kameez as their school uniform switched back to skirts, at least so the legs of the girls are exposed to sun during the break time. So I think if gradually more and more awareness is created, people will take on exposing themselves to sun. And the fear of exposing themselves to sun is of skin cancer. These dermatologists are creating havoc, you know, and the pharmas which are selling sunscreen creams. Yes.
Fairness creams.
Fairness and SF sun protection creams of factor more than 8 or 15, whatever. They decrease your synthesis of vitamin D by 90%. So all girls, I was not aware when I was giving a talk in her college, when I came to know that 50 to 60% college girls are using sunscreen the moment they leave the college, go out. So, I mean, that's the kind of usage that they have. So I think this fear should be not there, because non-melanoma cancers, one, are very benign, and two, they do not occur. You have to be genetically predisposed to have skin cancer. Otherwise, all our laborers and chartwalas standing in sun, rickshawalas would be having skin cancers. So please forget and don't worry about skin cancer. You as Indian are not prone to getting skin cancers on exposure to sun for about 20 minutes a day. The other problem is, what is the amount of sun exposure that you should get, which is very difficult study. I tried to do it, but I failed. Because exposing sun for 15 minutes, 20 minutes, 30 minutes, till there is redness of the skin, you don't synthesize. It's just not that you go and show your skin and you will form vitamin D. So that is another problem. So noon assemblies can be one. We have already discussed about fortification. But the principle behind should be that, all right, at least all of us should have 12 nanograms so that we don't at least have bone morbidity among our children. You will be surprised that we have shown almost about 35% of healthy Indian men and women above 50 have osteoporosis. Almost 14 to 20% of healthy elderly people have got early morphomotoric fractures. That is, in the vertebra. They don't even know about it. It's only when they fall or something happens then they come to know. So that is the kind of problem that we are facing. So if you have to tap a crowd, it should be children, where you give them adequate calcium. So you people do not give any importance to calcium. All we talk is of vitamin D. Calcium deficiency itself worsens vitamin D deficiency. And it is the calcium which forms your bone, not your vitamin D. Vitamin D helps in absorption of calcium. So if you have vitamin D, you have given vitamin D, but you don't take calcium, what is the purpose of vitamin D? So please remember that adequate calcium along with vitamin D is together is going to give you healthy bone. And I said peak bone mass, which these children will form only till 20. Girls at least only till 18 you form peak bone mass. In men, it is up to 30 years. So after that, you're going to lose your bones. So that is the time to catch these children young, give them adequate amount of calcium and vitamin D. Have I answered your questions?
Thank you so much. Well, I'd just like to add to what Dr. Marwa said, and it's very, very valid. We did studies on girls, and interestingly, about 4,000 girls, and when the uniform, from second to ninth standard, when the uniform changes in the fifth or sixth standard, from a skirt to a salwar kameez, the vitamin D levels drop drastically. And also we found there's a lot of, because of the preference for fair skin, there's a lot of use of fairness creams, which was very deleterious. So I think these are social issues also, which get entangled in this whole mystery of vitamin D deficiency, which we really need to address. Coming back to you, Dr. Nair, we talked about milk and oil. What about other food vehicles which could be used for fortification of vitamin A and D? What would be the challenges? Because there's also been a lot of debate about if multiple food sources are fortified, it may lead to toxicity and it would be dangerous, and therefore we cannot make it mandatory. So could you throw some lights into these kind of controversies which have been troubling fortification strategies?
Thank you, Dr. Seema. So first, what we need to bear in mind is vitamin A and D are oil-based, best for absorption. So the reason why we are talking it in the liquid medium, milk being a colloid, oil, a better absorption because intestinal cells would absorb it much faster with all the vitamins, minerals, whatever we are consuming, whether it is fortified or from the diet. So the first part is to start with the process. We wanted oil being consumed by all families. Without oil, India is not cooking. So at least 30 grams of oil is what we had decided per day. And based on that, the standards were developed. Now, in the PM portion and the PM's recent addresses is to consume at least 10% less oil in all families. We need to now relook whether the public is going to get that same level or not. The issues which we face is first is so say from if we move from oil, then the other sources are to have butter, cheese, or anything which needs to be fortified. Now, what population or which sector of population is going to consume that much of butter and ghee? Now, we do not want to also go on high fat because we are taking consensus to reduce high fat, salt, and sodium. And therefore, we need to also keep that in mind. So, India being also capital for NCDs, and now a lot of youngsters are developing cardiovascular disorders. That is the second kind of question which comes to the platform when we are addressing this. So, to be on safer side and to look at the large public health perspective, when we talk from FSSAI, that would be the more concerned aspect to address the public at large. What we will need to do is, with the 10% less consumption of oil, we will have to look into recalculating the existing amounts of vitamin A, D, which is coming into the system. And we had a consultation meeting for addressing the premix issues, because the quality of premix really matters when we want to do the fortification for mass consumption. And that is being taken care by FSSAI. We are now redoing the standards a little bit, so that yesterday also we had a stakeholder consultation on that. And we are looking into some of those aspects to see how best we can move, because we need to keep all the manufacturers, all the premix people who are in the system, and at the public interest, public health at large as a concern. So that's how it is going to move.
Thank you. Thank you so much for those insights. Ruchika, you are the nutrition lead for the Gates Foundation. Has Gates Foundation taken any initiatives to address this issue?
Yeah, thank you so much, Dr. Seema. So at the foundation, the vision is to ensure that each woman and child has, gets the right nutrition to lead a healthy and productive life. And we look at a very wholesome approach wherein the focus is to address this triple burden is, and our focus as part of our strategy is, one is to work in very close coordination with the government strategy. So we really focus on how we can improve the diet system. So really focusing on nutritious diet systems. And there is a lot of conversation in terms of whether our diets are affordable or not. So one is the intake of wholesome food. The other is also whether they are affordable. So there's a lot of focus on nutritious diet systems. The other piece where we really focus is the vulnerable age group, which is the maternal and the infant young child. And there the focus is on maternal nutrition, how we can prevent early wasting. And anemia is the key theme. The third pillar is how we can tackle micronutrient deficiencies. And within that, the core micronutrients, and Dr. Sasikaran also mentioned iron, folic acid, B12, vitamin A, D. And now the data is also coming on other nutrients like in Assam. There's been talk about, we thought beriberi is eliminated, but we are seeing infantile beriberi. So how we can kind of look at various strategies to address micronutrient deficiencies. Because what we are seeing is, be it, undernourishment or overnutrition, micronutrient deficiencies are really rampant. And it's really important how we fill the missing nutrient gap till we reach the ideal state of having the nutritious diets. So over the years, we have been working very closely with the government, with the regulator in terms of supporting in efficacy, effectiveness study, operational studies, supporting in standard setting. And as mentioned, we have standards for A&D for oil and milk. Open market has played a big role in. And as Supreet mentioned, right now we have reached, when it comes to open market with fortification of A&D, it's good saturation, but the issue is, since the standards are voluntary, they the quality in terms of the fortification as per standards, there are huge gaps. So that's one area where we are really focusing in partnership with the development partners and with the government. The other piece is the awareness bit, which I think everybody discussed is really important when it comes to the wholesome food and the micronutrient intake. Third, I mentioned testing is really important. And as the government is also looking at conducting frequent micronutrient testing, and right now the diet and biomarker study is happening, how we can support and work with the government in terms of building capacity for micronutrient testing in the country as well. So that's another key theme which the foundation is focusing on, again, closely working with ICMR and NI. Stop.
Thank you. Supreet, you are with GAIN, which is the Global Alliance for Improved Nutrition, and you worked on this issue in many countries. Could you share some experiences from the other countries?
Yeah, I think, thank you, ma'am. To see the experience from our very immediate neighboring countries, both Pakistan and Bangladesh, they are into the space of mandatory oil fortification. And the program there is very matured, and through the impact evaluations, we have seen that the odds of the deficiencies of vitamin D has really reduced and significantly reduced, especially amongst the women and children. So, so that shows the case that once the, once we are in the place of mandatory, signatory with the government, and government is taking it forward at a scale and ensuring the quality, then the deficiencies are also in control, and whole mechanism is working towards it. We There are an ample number of studies and evaluations available from right from UK to European countries to Canada's and US of the world. But when we are seeing the similar type of approach in our similar geographies is happening, it's high time to actually go forward for it. And while doing so, I think it's not a very difficult thing to achieve. And seeing the cost effectiveness of it, and reaching of it, and Ruchika very correctly mentioned that it's high time that we set the testing norms, that how the testing needs to be done. We need to cut the cost. We need to work with the industries to understand their perspectives as well. There has to be capacity building from their end, that they should be knowing what technology is happening, where they are going wrong, what needs to be corrected. I think at GAIN, we are ensuring that we are at present working with more than 125 oil industries across 14 states, and we try to build their capacities. And I think at present around 11.6 million metric ton of fortified oil is being produced annually, and we ensure that through our efforts we at least try to make the quality food available to the people to combat this deficiency. Thank you.
That's great. And I think now we can open the discussion for the audience. And anybody would like to ask, we could take a couple of questions. Is that right, organizers? Sorry, Dr. Nair would like to say something for a minute.
Just one addition I would like to make is, since other food items were requested, the other food items, as I said, would be for easy for us to fortify would be milk products, where we have India is definitely consuming good amount of cheese and butter and things like that. Only thing is the technology transfer needs to be done. That is one set of things which is completely different. And at the same time, if there are volunteers who would start that, I think FSSAI will welcome that. So that, because anything which is new, they have to just write it to the CEO, and you will be called for a discussion with the scientific panel. And if you are able to do some of those programs, welcome most. Thank you.
Thank you. Yes, sir. Sorry. Sorry. We have a very enthusiastic
Mrs.
panel.
Nair, why don't you fortify water through the normal supply so
Absolutely.
everybody gets it?
Absolutely, yes.
The water supply
Actually,
thing had come.
I was going to ask this question, that why the fortification is limited to oil and milk? Why not to all juices and water?
Okay, so for water, this question was the first thing answered, because water everybody is drinking. All are not drinking the same water in India. Some are having different pipelines coming. Some have bore well, some have river water. So the issue of that is totally different than the purview of FSSAI, because government has to invest. There is one program which is happening in Gujarat. It needs to be scaled up. They are trying to change the sea water to drinkable water. The technology is being done at Bhavnagar, which is CSM CRI Institute, and they are trying to bring this into a large scale.
This question is especially very important. This issue is very important because when you visit the North America, US or Canada, all the juices and water even, all the milk and milk products are fortified with vitamin D.
So Canada, now when we look into the fortification process, Canada and Denmark, Finland, they are comparatively on a colder zone. So the requirement is different out there than compared to Indians. But now Marva sir is giving more details of the studies which are coming out. So I am sure India will look into more aspects on that.
Just wanted to
I have,
answer. Just wanted.
I have a question with General Marbaha.
Sir,
Okay, sure.
Wait for the answer.
Yeah, so in India also, if you look at regulation as a proprietary food, various vitamins and minerals can be added. You are aware health food drinks are there like Horlicks, Complan and others, which add multiple vitamin minerals, including vitamin D. Some of the fruit juices are also fortified, so it is up to the industry, but then whether it can be consumed by everyone in terms of social economic strata, that's a question. But these can be fortified. Our regulation permits it. Just wanted to call
Yes, the
that out.
regulation says it as enrichment, not fortified. Fortified will have a plus F logo. Please bear this in mind.
And the level can only be up to 1 RDA.
Yes,
Not,
one RD,
not more than that.
not to cross that.
My question is with General Marbaha again.
Can you please introduce yourself, sir?
I am Professor Afrozul Haq. I am the Pro-Vice Chancellor at Manipur International University, Imphal. And I'm involved in vitamin D research for the last 20 years. And I had the opportunity to invite Dr. Marbaha to Abu Dhabi when I was doing an international conference there. So my question is with Dr. Marbaha, when you were talking about exposing of the kids to the sun for the whole year, and there was no difference in the vitamin D levels.
Gases, ozone and other things which obstruct UVB radiation. So we are trying to correlate environmental pollution with the synthesis of vitamin D. That is one. What was your second question?
Yeah, my question was how much the percentage of
Right,
the skin.
right. So you can't change the uniforms. You have to go by what the uniform of the school is. So we took children above 6th standard and children below 6th standard. So below 6th standard, they were in their shorts. So the exposure was with both the legs, it was 30%. And older children with just face, neck, and half the arms was about 15%. But when I say 30%, it does not actually mean 30% because you can expose only one part of the one face of the leg, not the backside. So, but for conventional reason, we say, okay, one leg is 30%. So 15%, 50%. So I think it is half of it what we said, but conventionally we will say
So
that
25 to 30% of the body.
15%. Right. So that's how. So we clearly showed that those who were exposed 30% of their body surface had significantly higher vitamin D synthesis than those who had exposure of 15%. We also said or also observed that those who had lower baseline levels of vitamin D had significant rise as compared to those at higher baseline. And what I want to highlight here is about this fortification studies. What we introduced in 18, the amount that we added in the milk was 200 to 300
IU of vitamin D in 1 liter of milk.
Right.
So usually the Indians consume is about 250 ml per day, right? Maximum. And so what will you get is about 70 to 80 IU per day if you consume 1 glass of milk. We added 4 to 6 units of vitamin D per gram of oil. So if you consume, normal consumption is between 20 and 30. So even assuming we consume 20, so we'll have about 80 IU of vitamin D. So out the maximum is about 150. So we did this study, which was supported by Tata Group, was that we added in milk 240 IU of vitamin D, which if you're consuming vitamin D fortified milk and vitamin D fortified oil, what is the impact? And what we saw was that the control group who had vitamin D levels of 11.6 nanograms over 3 months, it came down to 6.4 nanograms. So in the winter, you don't form, but whatever is available gets metabolized over 3 months. So it fell down from 11 to 6. But those who had got 240 IU through milk, it was 11.6 and it remained at 10.7. So there was no increase. It just basically was about to maintain that levels through winter. So what I'm trying to say is that we had recommended higher dose. I don't know how it happened in Food Safety Authority of India that they reduced it, but that's the question. But what I'm saying is, unless you do evaluation studies after you recommend a particular dose, you just can't go to the government. That's what I keep saying, mandatory, but you do not know what is your normal level and how much should you add to bring everybody's level to 12 nanogram is what you should do first before you make it mandatory.
Yeah.
So, madam, this is for you. That you can't just start off with mandatory
taken, sir.
modification and say, okay, we do not know whether it is 400 IU, whether it is 600 IU. We did this study with 600, 1,000 and 2,000 IU children given for 6 months every day. And it was 2,000 IU, which made 95% of children reaching above 20 nanograms. But the problem with adding 2,000 is that some of them will achieve 30 to 40 nanograms.
Yes.
So that is the reason. But 1,000 is certainly required for us. Why? Because we are dark skinned, we form less of vitamin D, we don't expose, and we have low intake of calcium, which further worsens the vitamin D deficiency. So I think that is the reason why we need more. So we have done all studies, but to achieve 12 nanograms, I do not know what is that level, whether it's 400, 600. So you must do these studies before you make anything mandatory.
Okay,
thank
so
you.
just
Want to react
adding,
to that?
just adding to that, so that this is a question of different states coming into the system. So when we did the fortification, the first state totally refused was Kerala for any fortification. Now they have some of those districts, some of those units where their rice is getting fortified. Kerala now has put oil and milk by the Milk Federation itself for fortifying with vitamin A and D. All their curd also is getting fortified. So at present, Kerala is one state and Tamil Nadu is taking up their milk and curd is also getting fortified. So I think slowly India is gaining the momentum. But as Sir said, we'll look into the data for more inputs which would come.
Thank you. I think, sir, there are some people at the back. You can carry on the discussion over lunch. At the back, can you? Yes, please. You raised your hand. Can you share the mic at the back, somebody?
My question is that there is a lot of difference between the supply consumption and production. What are the consumption is required in India? What are the production required in India? There is a lot of gap
Of
between
what?
that
Consumption and production of what?
for nutrition because vitamins.
Will you stand up?
Yeah, he's
Can
there.
you introduce yourself, please?
Yeah, and please
Yeah.
introduce yourself.
Yeah, please tell us
what
you want to know.
I want to ask one question. There is a lot of difference between the consumption and production vitamins. So how to
Vitamin production
define
and
the
consumption.
accountability for the consumption, because कई बार पेपर में भी छपता है कि
Okay, I've got
consumption.
your point. I've got your point.
Please
I will
introduce
give you-
yourself. आप कहाँ से हो?
I am from media. कब तक media news?
Okay, fine.
So I'll give you an example of universal salt iodization, right? So we have recommended addition of 30 ppm of iodine to salt, which means you can add 30 milligrams per kg of salt. Now that is at the manufacturer's level. So you have losses of iodine on way coming, being transported to distant places, rural areas, and then you have the shopkeepers where there is a loss. So with the idea that at the consumer level, you get about 100 micrograms of iodine, considering losses on exposure of salt where the iodine loses, or when they are kept in the kitchen, out in the open bins, then again there is a loss. There is a particular 5 to 10% loss during cooking. Having considered all this, that's why we add much higher levels at the manufacturer's levels, so that at least the normal requirement of iodine is met, day-to-day requirement met with that. So have I made yourself clear?
Yes, thank you. Gentleman at the back. Yes, please. Please introduce yourself very briefly.
This Sharma, I'm a freelancer. I have a
Okay.
very technical question.
Sir, mic on कीजिए.
Hello.
Hi.
Yes, I'm Dinesh Sharma. I'm a freelance journalist. I have a technical question. What is the lifespan of a vitamin when it goes into the body? Suppose if I take vitamin D in the morning, so in terms of metabolism, how long it serves the purpose in my body? 1 hour, 2 hour, 20 hour, 24 hours. Some
Lifespan of
doctor-
vitamin D in the body.
in the body in terms of metabolism. Related to that, some doctors advise very high level of vitamin once a year to be injected into body.
Okay, I'll tell you.
Yeah.
Now I've got your point. So you don't understand what is half-life of a molecule? Do you understand? So the half-life means if you take something today, half of it will be metabolized on after a few days. So half-life of vitamin D3 is 2 to 3 weeks. So for the vitamin D3 to be completely metabolized, today you have taken some amount, for it to be completely disappearing from your body, it will take 3 to 4 months. The maximum will be at 4 weeks. So today, whatever dose you have taken, the maximum you will see is at 4 weeks. And then it will be completely degraded by 3 to 4 months. So if you have taken today and you don't take it again, at 3 months again, you will be back to square one. So that is what happens with most of the people. Now, whether you take 2,000 daily or you take 60,000, why do we give once a week or once a month? Is because of long half-life. So it stays in your body. So we don't have to rush giving every day. If you take D2, you may have to take more frequently because of shorter half-life. If you take active vitamin D, the half-life is only few hours. So it disappears very fast. So you have to take every day. So depending on what preparation you are you taking active vitamin D or you're taking conventional vitamin D3? So it depends on the half-life. Have I made myself clear?
Thank you. I think there was one more question. The last one we'll take. Yes, please.
My name is Suresh. I'm a content writer for Value Enablers Academy. I have 2 questions. One of the former speakers mentioned that glass windows do not permit the passage of ultraviolet rays. Do latticed windows like the one at Hawa Mahal in Jaipur, which offer natural lighting and ventilation, permit passage of ultraviolet rays? Second question is, the one side the union government is promoting organic farming, other side it is supplying fortified rice to the public distribution system, which has synthetic materials. Is there a contradiction in these approaches?
No, I can answer your first question. I didn't understand the
Second
question.
Dr. Nair can take. First
The
question you
question
answer.
is anything which comes on way of UVB rays whether it is, if you sit under tree also, you will not get UVB rays. If you wear clothes till here, this portion will not get UVB rays, right? So this glasses, if you have window glasses, the sun rays, you may feel that the sun is coming, but you will not get UVB rays. So please expose yourself directly to sun, all right? Now, second question, I don't know.
Second question, if I've clearly heard, you wanted to understand one part is on saying that we should consume and the other says not to consume. Is it so? Oh, organics versus fortification. Now, the country is a democratic country. Fortification is one aspect to address public health at large. So, looking at the masses, we are recommending public health. One is free to choose. आपको क्या कंज्यूम करना है आप कंज्यूम कीजिए मार्केट में आपको बहुत कुछ चीजें जो अवेलेबल है एफएसएसए अगर लोगो देखा तो वो प्रोप्राइटरी पे अवेलेबल है पब्लिक डिस्ट्रीब्यूशन सिस्टम कंज्यूमर अफेयर्स पे देखते हैं उनको है राइट्स पूरा इसको लीगलाइज करने को Does that answer your question?
Okay, Ruchika. To it is the whole ethos of staple food fortification is, and why staple? Because be it rich or poor, droughts or floods, people will continue to have their staples. So they might reduce their pulses, fruits and vegetables because they are expensive. So that whole ethos of fortification is that the staples are fortified, which are consumed by all economic strata, and to fill the missing nutrient gap. So in the report also it was mentioned, and also the data which shows us that there is rampant vitamin D deficiency and certain micronutrients. In the case of rice, it's iron, B9, B12. So based on that, the government takes a decision in terms of these are the dietary or the nutrient gaps. And to fill that, since it's mass intervention, it is added just 1/3 to 1/5, half the RDA. So that whole thing of toxicity doesn't arise. So that is the principle when it comes to fortification. The supplements are also synthetic. So if you're not, ideal intervention is dietary diversity, which the government of India promotes. But when there are gaps, while they are making a lot of efforts, since I mentioned about diversifying the food basket through PDS and pulses and other food items, to fill that gap, this is the medium-term approach which is used. Yeah, thanks.
Okay, thank you. I think one last question, the lady at the back. No, sir, big over lunch. Otherwise, we'll all be deprived of lunch. And I can see people are saying, let's move on. So please carry on over lunch. But yes.
Good afternoon, everyone. Thank you so much for all your inputs. My name is Gauri, and I'm a PhD scholar at St. John's Research Institute, Bangalore. And my PhD also revolves around vitamin D supplementation. However, there are people in the lab also working on vitamin D2 enhanced mushrooms. I just wanted to know your opinion on the potential of vitamin D enhanced mushrooms. Since we know mushrooms on exposure to UVB also the vitamin D2 levels get enhanced. So I wanted to know your opinion on mushrooms enhanced with vitamin D being a potential dietary source, especially for vegetarians, where we know the very few vegetarian sources of vitamin D.
You know how vitamin D is formed through mushrooms? You expose mushrooms to UVB rays and form. Otherwise, mushrooms directly will have very little unless they are grown up in the sun.
True.
So they will have some amount. All these plants, right? The fungi and other things, when they expose to sun, they form vitamin D. So in the market, when you get radiated mushrooms, that they've been exposed to UVB radiation of that particular wavelength of 290, then the formation or synthesis of vitamin D takes place in the mushrooms, not by itself. You can't add over and above.
No, so yes, definitely. There are people now actually selling vitamin D enhanced mushrooms by
So that's why I'm saying
exposing it to
yes.
the UVB.
So you can also take UVB rays in your room. People do take UVB rays in the room to synthesize vitamin D.
Yeah, in Denmark and all, they have these lamps, UVB lamps, which they expose themselves to regularly.
So I think
that's it. And
I'll just
so
end
we'll
by
close the
saying
discussion.
Yeah.
Last words by Dr. Marwa.
No, this is only for,
And
for people like
Mr. Chaudhary.
Chaudhary and for her, is that I traveled across the country, evaluated midday meals across about few states. Everywhere it is different. There is no uniformity in supplying midday meals. In Delhi, they don't provide fortified ration to the midday meal program. In Pondicherry, when I went, they were being provided as many eggs as you want, chikki in the evening and things. Vishakhapatnam was different. Gwalior was different. So, you know, the government should make a policy decision that they are going to provide. Some people are providing milk also. Some people are providing only egg. In Delhi, they provide fruits for 2 days. I mean, I don't understand what is going on. Once the decision was taken that all these midday meal programs should be provided fortified wheat, fortified rice, so that all these deficiencies are taken care of. But it is the implementation which you people need to concentrate. Policy decisions are there. All these things are available, but I think the implementation uniformly is not being done. So this is for people like him to undertake with the government and she at Food Safety Authority, make sure that all states do provide.
Actually, Dr. Marwa, I think the problem that comes in is that policy is made at the central level and the implementation and the budgets are at the state level.
No, some rich
And
states
therefore
provide.
yeah,
Yeah,
so
rich
that's why there's a diversity and
the point
variation.
is that if you can have uniformity at least in the midday meal
Yes.
program, I think that will serve the purpose.
But
Otherwise,
that's-
we keep discussing and
That's where the major
Yeah, the-
differences occur
Correct.
because
The
of
midday
various
meal
reasons.
mandatory says rice, wheat, and oil to be fortified for all school health programs. And it is a must. There are some evaluations happening, but everything is not out into the public. As Sir said, the states have the budget. The budget has been allocated to the states. And as he said, some states are giving eggs, some states are giving milk. But for midday meal cooking, it is a mandatory process that they have to use only fortified food products because we do not want the children when they are, by the time they are 17 and 18, to have their deficiencies. Especially for the girl children, there is additional program through the ICDS when they are dropping out of the school. We are giving them a THR of 5 kg with 22 micronutrients in that so that they address the other deficiencies which are also coming in. That is done through Women of Child Health and Development Department. So there are multi-prong approaches to the system, but as you said, implementation from state to state is varying. It's a sad state of affairs because we are spending money on this.
but there is one adverse aspect that you need to remember is that I've seen now 5% obesity in government school, which I had never seen.
Yes,
There is
yes.
no control over how much you give to the child. They are eating complete twice, thrice, as much as you want is being given. In fact, there's so much in excess. I ate midday meal throughout my travel across in Delhi. And you eat as much. So they eat like mad. And 5% obesity in government school children is unheard of. In public school, it is 20% gone up. When I last studied, it was 5% in public school. But now it is in government school. So that is creeping in. So we have to
There's
be
a lot of
careful.
talk about targeted midday meal, and all.
Yeah.
I think it's a very animated discussion. And as you can see, all the panelists are also very animated about this issue. And we shall continue the discussion over lunch.
Sure.
Thank you so much. I extend a very warm thank you to each and every one of you for keeping this discussion going, both from the panel and the audience also, for bearing with us. And we are not standing between you and lunch. So thank you once again, and thank you, the organizers, for giving us this opportunity.
Thank you
having
so
these
much.
discussions.
Thank you, everybody, audience, for a patient listening with all of us. Thank you so much.
So, like you said, ma'am, a very, very engaging and brilliant conversation we all had. May I request Dr. Ashish Chaudhary to please thank all the guests, all the panelists, starting with Dr. Seema. Dr. Raman Marwa, sir. Dr. Srima Nair. Ms. Ruchika Jogs. And Dr. Supreet Kaur. May I request sir and all the panelists to stand for a quick picture, group picture. Thank you. Thank you, sir. Thank you, ma'am. Now we are towards the end of the day today. May I request Ms. Trishali Khanna to conclude the day with a vote of thanks. Ms. Trishali is a research assistant at ICRARE. Welcome.
Good afternoon, everyone. As we conclude this event, I sincerely thank all those who contributed to the successful release of the report. We are grateful to Dr. Ashish Chaudhary, Managing Director of Akash Private Healthcare Limited and Director of Anvika Foundation for collaborating with ICRARE and for setting the tone of the event with his welcome address. We at ICRARE are immensely grateful to Dr. Raghu, Deputy Director General of Ayush, GGHS, Ministry of Health and Family Welfare, Dr. Shashi Karan, MD and former Director of National Institute of Nutrition, ICMR, and Dr. J.C. Chaudhary, Chairman of AHPR, for taking time out of their busy schedule to join us for releasing our report and sharing the valuable insight. We thank Dr. Seema Puri, Professor at Institute of Home Economics, University of Delhi, for moderating the engaging panel discussion on roadmap towards vitamin D Kuposhan Mukt Bharat. The insights shared by our distinguished panelists, which include Dr. Raman Marwa, Dr. Srima Nair, Dr. Ruchika, and Dr. Supreet Kaur, were truly enlightening. To everyone who joined us today, both in person and virtually, thank you for your engagement and your thoughtful questions. They enrich this event immensely. We are also grateful to ICMR, NIN, NPPA, CDSCO, NIFTM, GAIN, United Nations World Food Programme, and FSSAI, along with their experts, for the support they provided during our consultation. Our appreciation goes to all stakeholders who participated in the consultation and KII. We would especially like to thank Dr. Rakesh Pandit, Dr. Harpreet Kaur, Dr. Preetham, and Dr. Mani Pandey for their support and expertise throughout the study. We thank Ms. Kulpreet, founder and MD of Impact PR, and Mr. Ankur Sharma, media head of Impact PR, for the media support they provide. Within ICRARE, special thank goes to Ms. Anushka and Mahima for their contribution, Mr. Anu Mohan Das for secretarial support, Ms. Chaya Singh for library assistance and administrative and finance team, which include Ms. Neha, Ms. Anvi, Ms. Rajesh, Mr. Rajkumar for their hard work. Finally, we thank Mr. Sanu Kapila of Academic Foundation for printing the report. Once again, thank you all for making this event a huge success. I now invite all of you to join us for lunch. Thank you.